Hello, everyone. I'm here again introducing myself. My name is Daniela Robledo. I'm one of the CP 237 TAs. And today I will be talking about cultural diversity in community practice, and this includes healthcare settings. Just a little bit about me. I'm a second year master's student in the counseling psychology program. And this topic is very important to me because we usually only get one class in our program and in many training curriculums around cultural diversity, cultural humility. And so I'm hoping that whether you're new to these terms or whether you have experience with these terms, you'll be able to gain something out of it and maybe learn something new. So my objectives for today are giving you an overview of cultural humility and cultural competence and what that is, and briefly talking about intersectionality, as well as talking about cultural competence in healthcare and mental health, with using the experiences of Latinx patients that have been studied, as well as barriers to access for Black Americans, and then learning from Native Americans what is most effective in mental health services specifically. So we'll get started. And just to broadly define what I mean by culture, culture is socially shared beliefs, values, norms, and practices considered most relevant to psychological and behavioral phenomena. And I just like to ask you to reflect maybe on your own culture and how that influences maybe your behavior or your expression, your self-expression in this world. And so culture is a very important aspect in our lives that govern a lot of our emotional and psychological processes. So I'd really like to encourage you all to reflect on your own culture. And a lot of people say, I don't have a culture, and that's not necessarily true. Culture can be based on a lot of things. And so we'll get into that in the next slide. So I want to define also cultural competence and cultural humility. They are a little bit different. They were coined by different people. And so here are the two definitions that I have for you all. And please note that there are many definitions and models to these terms. So cultural humility is a lifelong commitment to self-evaluation, to redressing power imbalances. And what I mean about power imbalances is the inherent differences in power dynamics between providers and patients or clients. When we are a provider, we hold more power because of our training and background. And a lot of the times this can perpetuate some of the powerlessness that clients can feel coming in terms of just not having their own voice being heard when it comes to treatment planning. So that's just to give you an example. And power imbalances can show up in a lot of different ways. As well as developing mutual beneficial and non-paternalistic partnerships with communities. So that is also part of cultural humility. As for cultural competence, this is defined as behaviors, attitudes, and policies that ensure a system or agency or program or individual can function effectively and appropriately in diverse cultural interactions and settings. It ensures an understanding and appreciation and respect of cultural differences and similarities within, among, and between groups. So I know that was a lot of words, but for the purpose of this presentation, I will be using cultural competence and cultural humility interchangeably. I think there are a lot of debates, whether one is better than the other. And I think that for this, I want to kind of use a both and approach. So I think that just knowing that either term is reflecting our continuous learning and self-evaluation or self-reflection of different cultures that are different from the one that we grew up with or in. Just to give you some context or historical context, Melanie Turvalon, who was a public health physician, and Jane Moray Garcia, who was a health educator and clinic administrator, they both introduced cultural humility over 30 years ago. And it's basically, sorry, I lost my place. I want to pause there. I want you to reflect a little bit about what it means for you in your relationships with others. What would cultural humility look like for you? If you can't answer these questions, that's okay. But I'd like you to think of maybe a time where you went to a doctor's visit and you didn't feel understood, and how that doctor or provider might have responded with more cultural humility. And in this presentation, I hope to expand more on these terms and how this skill, because cultural humility is a skill, and how this skill can give you an opportunity to help diverse individuals and communities in your work, and to continue to increase this awareness around intersectionality, including our own work, and to continue to increase this awareness around how this impacts the work that we do with communities that have been historically marginalized in public health settings specifically. And even in the treatment for mental health, I think there's a lot of, historical context or events that have influenced people seeking out treatment or not seeking out treatment. And that is like, I think that there are a lot of nightmare stories. And I have also witnessed a lot of people that seem to have zero awareness of their positionality. Where they're rooted in their cultural context and how that influences their work, and how to express cultural humility towards the people that they're caring for or providing services for. And if you have not seen Kimberly Crenshaw's TED Talk on the urgency of intersectionality, I really urge that you watch this video. It's listed in the week 3 review module for you to access that. And I will also touch on that in this presentation, but Crenshaw is the one who coined this term, so I'd highly suggest hearing her present it. Going back to cultural humility, there were trainings and educational curriculums that were developed for practitioners in health promotion when this term came about. And so maybe you all have heard more about cultural competence. It is possible, since that arrived a little bit earlier. This was developed in the 80s by social workers and counseling psychologists. And the concept of cultural competence is permeated in the healthcare field. And so when cultural humility was coined, it became a debate about which term was best. And one of the main critiques of cultural competence is that we can't ever truly be competent in someone else's culture. And this goes beyond racial and ethnic culture. So think about your culture that is based on your social context, and most importantly, your intersectionality. So notice again how I'm bringing up intersectionality in our discussion. And this is very important to reflect on. And I want to give you an example of different cultures. So you might have a really good friend who you think shares your together. Maybe your friend might have grown up in a household with married parents who were well off, and let's say they had a strong faith in religion, where you might have grown up in a household with divorced parents who might have been struggling to meet ends meet and to make ends meet, and were not active members of any particular spiritual group. All of these different dimensions intersect with one another to create a unique culture that influences how you see the world. This is what results in biases, and we all have them. We need to accept that. I've definitely made mistakes and that I've behaved in ways that are reflective of my biases and my blind spots. And this is partially because I may not fully understand someone else's cultural context due to my limited experiences. And so I have been called out, and that's completely, I feel like that's something that I have to own and accept for, my lack of understanding, and to move on from that experience, taking away more knowledge, more awareness, and more skills so that I can become better. So there's another critique of the term cultural competence, and that is the sort of top-down approach that emphasizes the power imbalances that exist in providers and clients. Like I said previously, we usually have practitioners that are highly educated and live as privileged members of society, and they decide what is and what isn't culturally competent. So it creates this binary of what or who is culturally competent or culturally incompetent. Now, there are authors that have examined this controversy and argue how they can both be used to complement each other, or that cultural competence implies cultural humility, in that it is calling people to question their assumptions, their beliefs and biases, and ultimately respecting differences while decreasing power imbalances to build better relationships with clients, and taking a more humble stance to learn about their culture. So whether we use cultural competence or cultural humility, we need to understand that it is not about being competent or incompetent, but rather to continuously strive to learn more about different communities and cultures through this lifelong process of self-reflection. And so, yeah, I'm going to move forward. So I previously talked about intersectionality a little bit. Again, this term was coined by Kimberly Crenshaw. And intersectionality can be talked about as a framework, a theory, a methodology, or a paradigm. And the overarching theme is that humans are built and influenced by their unique social locations, which can be based on race, ethnicity, indigeneity, gender, sexual orientation, class, geographic location, age, ability, disability status, as well as migration status and religion. And these intersecting social locations or identities that we hold exist within systems and structures of power. And this includes laws, governing institutions, and even the media. So due to colonialism, imperialism, racism, homophobia, ableism, and the patriarchy, there are forms of privilege and oppression that exist. However, I would like to advise you to not think of privilege and oppression as black and white or as binary. Think of it as a spectrum where, depending on where your context is, you might be more privileged in some settings versus other. So I want to give a personal example. My social locations include being an able-bodied, cisgender, queer woman, second generation Mexican American immigrant that has grown up in a working class family in the Midwest with a spiritual orientation towards life. And although I belong to a Latinx social group, which indeed has faced serious discrimination in immigration policy and law here in the US, I am a white passing US citizen that has been able to acquire higher education, and therefore I experience privilege in a lot of ways. When I worked as a bilingual family support specialist before coming back to school, I worked with Latinx families living in Dane County, and I really had to be aware that although I might share a culture with some of my clients, I may not fully understand what it's like to live with some of their social locations as it relates to migration status, age, and class. I have also experienced oppression in forms of microaggressions. So I, at a predominantly white institution, I was not believed in my capacity to succeed in harder courses, or I was questioned about my immigration status in the dorm. So I think that these experiences have really made me think more about where I hold privilege and where I might be oppressed. So it really depends on the context for which you're experiencing um, these different forms of privilege and oppression. So next, um, I want to introduce you to the foundation of the Multicultural Guideline, which was adapted by the American Psychological Association. And this guides the development of models for training and counseling in clinical psychology. And it is of importance to have these kind of conceptual models to teach providers that their cultural competence can shape the interactions that they will have with culturally diverse patients or clients. So the cultural competency domains are beliefs and attitudes, which is a provider's awareness of biases when working with clients. It's also another domain is knowledge, how much the provider knows about the patient's culture and worldview. And then skills. Provider can communicate sensitively and relevant to patient's culture. So these are all domains that we have to take into consideration when practicing cultural competency. So here we're moving on to cultural competence in healthcare interactions. I present to you Betancourt's integrative model of culture that was adapted to study health behavior and health outcomes. This is a framework that explains the role of culture in healthcare and is used to assess which factors might be associated with cultural competence. In the chart that you can see here on the slide, the model shows that the relationship between social, structural, and cultural and psychological factors to health behaviors exist for not only professionals, but for patients as well. So, socio-structural factors are made up of social locations, again, like race, gender, social economic status, and geographic region, to name a few. And then the cultural factors are the socially shared values, beliefs, norms, and practices relevant to healthcare interactions, which can lead straight into health behavior and psychological factors. Then psychological factors is defined as motivation and emotions relevant to healthcare interactions, while health behaviors include the kinds of interactions that are happening in healthcare. So this is just kind of a useful chart to see how all of these different factors come together to inform health behaviors. And so to talk a little bit of cultural competence on patient outcomes, there is a lack of clear theoretical conceptualization behind cultural competence that can make data outcomes inconsistent. And this ultimately makes it difficult to study the role of cultural competence on patient outcomes. I think there are more considerations now on like different variables that can be assessed, such as like psychological variables. And it's just, it's well known that there's a lower emotional burden associated in patients with diabetes that regarded their health professional as culturally competent. So it's really important for the patient or client to perceive the professional as culturally competent. And there aren't many studies that show a clear link between cultural competence and patient outcomes. And there's a need to increase providers' knowledge and awareness of the role of culture for the patient and provider alike. How are health behaviors of the patient influenced by culture? How is the provider making strides to understand how their own culture impacts the treatment of patients and the relational dynamic there? So things to keep in consideration, whether you want to become a provider in the future or work in the community, that cultural competence is definitely important to predicting patient outcomes. So then how does provider cultural competence impact patient behavior? Here, Flynn et al. 2020 investigated Latina and non-Latina white American patients that felt less ashamed, embarrassed in response to a negative health care encounter when their healthcare provider showed cultural competence. And cultural competence can be defined as having knowledge, awareness, and skills relevant to the patient's culture. So again, here's another version of the definition of cultural competence, just to show you that there are different ways of explaining it. And this is important because Latina patients might not come back to receive medical care in the future if they feel shame and embarrassment with healthcare providers. This is why it is important to train healthcare providers in cultural humility, cultural competence. However you'd like to think of it. I think that these terms are used interchangeably, but if you like to use cultural humility over cultural competence or vice versa, I think that's fine. But ultimately, it will have a greater outcome for the patient care on a relational level if those are taken into consideration when you're planning treatment processes or any other thing that has to do with the healthcare of a patient. So if you are in health promotion and health equity, if you're in that major, or even if you decided to take this class, I hope that that means that you care about redressing some of the hurt that people have experienced in medical settings on many levels, from the historical documentation of how doctors would experiment on Black women, to the microaggressions that are happening in healthcare settings that disregard women's pain. So if you are interested in that, I hope that the next generation, which is you all, will commit to the work of building that cultural humility and competence by doing your own research on a culture that you don't know very well, and also to keep in mind that mistakes happen along the way. And you might think you are doing something that to you seems culturally appropriate or sensitive, and sometimes the impact does not align with the intention, meaning if someone doesn't agree with it being appropriate or if someone is hurt by what you do, just own it, learn from it, and do better next time. One thing I want to emphasize is to continuously keep an open mind to new experiences. For example, if you are social and like attending campus events, attend the one that showcases different cultures. There are so many of these events going on campus, and they are welcome to all. So again, take your own initiative to learn about different cultures and to be open to that experience of learning. Okay, so we will move forward. So cultural competence in healthcare. So there is less medical avoidance of Latina women patients when they perceive the health professional as having cultural competence due to a reduced level of shame and embarrassment. And there's an increased patient satisfaction and trust with providers when cultural competence is perceived. So there was a study that found that when Latina women patients perceived health professionals as having cultural competence, they felt a reduced level of shame and embarrassment and had less medical avoidance tendencies. This shows that cultural competence doesn't necessarily influence patient outcomes directly, but can indirectly happen through psychological processes that reduce the negative interpersonal emotions. So the importance of quality relationships between provider and patient or client is the first thing that as a graduate student I learned in counseling psychology. And I'd like you to think about a time when you felt maybe misunderstood, unheard, or unseen by another person. It could be a friend, it could be a provider, and just ask yourself, like, did you trust them after that? Did you want to continue that relationship after feeling misunderstood? And kind of explore why or why not, why might you not be going to the same person about an issue? Is it because you felt that they weren't asking you, the right questions, or were they just giving you advice? So just imagine how that felt for you, and imagine how that feels for a lot of people from culturally diverse backgrounds that go into doctors' offices, and there's just that disconnect there. So these psychological processes affect our behavior in different contexts, whether it be with peers or at a doctor's office. So this study by Flynn et al. 2020, it ultimately argues that psychological variables need to be measured as it relates to disease, distress, patient satisfaction, and trust. Also, it was found that younger white American women have a difficult time perceiving providers that are not of the same gender as having cultural competence compared to those who received care from a female provider. This shows that cultural differences based on social locations, such as gender in this instance, impacts the perception of patients toward their provider and vice versa. So what would it be like to address those cultural differences sensitively in that context? How would you feel if a doctor who held different identities as you approach your work through a collaborative and respectful way that showed their interest in learning where you come from culturally, and to have that be integrated into the medical treatment? And I think I'd feel like the provider actually cares for me if those conversations were brought up. And that would ultimately positively impact the working alliance between the patient and provider. So then some of the critiques on cultural competence here, on cultural competence research specifically, is that cultural competence measures should be assessed from patient perspective instead of the perspective of healthcare professionals. And this is very common that the healthcare professionals are the ones reporting what is effective and what isn't. And then the lack of psychometric reliability and validity. There are just a lot of limitations in a lot of this research on the topic of cultural competence. And studies show discrepancies between physician self-perception of cultural competence and the patient's report of their provider's cultural competence. So the physician might say, oh, I have a lot of cultural competence, where the patient is saying, I don't believe that same provider has cultural competence. So this results in patients being less likely to follow through with medical treatments. So here we have negative healthcare encounters with Latinx. Latinx experience long wait times, poor communication, feelings of shame, anger, and dissatisfaction with their healthcare. And these are reasons to avoid future care. And that's because shame and embarrassment elicit avoidance behaviors. If I feel shamed, I'm not going to want to go to the doctor if I felt like I was being wronged or threatened. And so Latina patients have interpersonal emotions like anger towards a provider in response to negative experiences with healthcare providers, which predicts healthcare discontinuation. So I'll tell you a personal story that happened not so long ago, actually this summer. My aunt, who is like a second mother to me, she was going through many evaluations because she has a condition called neurofibromatosis, which needed attention and care. And it still makes me angry today that the care that she received lacked the basic warmth and acceptance of someone who doesn't speak English fluently and who has a hard time advocating for herself because of it. So just to give you the gravity of the situation, my aunt was experiencing severe migraines daily, and the initial MRI test showed a neurofibroma, which is just like maybe a little tumor in her ocular region, which she then needed follow-up appointments to see if she needed surgery. Well, it took 6 months to get those follow-up appointments scheduled, or I should say, the appointments were scheduled 6 months out. This is like a ridiculous amount of time, I think, because, if you say, someone has a small tumor in their brain or in their ocular region, like that's scary. So I called the doctor's office with her, and of course, I spoke because I am fluent in English, and I'm just overall a little bit more versed in how to navigate these systems. And I was able to get her an earlier appointment, but my question was like, why did I have to go through all of this to begin with? Like, why did I have to call again? Why couldn't they just give her an earlier appointment right off the bat, especially if she's in pain? And so I went to all of her subsequent doctor appointments. And I saw my aunt so nervous before going into these doctor appointments. I have never seen her like this nervous before. And she had told me that her doctor typically doesn't really listen to her and that she doesn't feel like she is understood or examined properly. So as a worried family member, I expressed my concern about this to the doctor, or actually she was a nurse practitioner, but I expressed this concern, and they did an exam. And when we left the clinic, my aunt said that was like the most thorough exam that she had gotten from her nurse practitioner, but that also she had taken more time to evaluate my aunt, and to talk to her and to talk to me because I was advocating a lot for my aunt. So this is what I mean about negative health encounters. People are scared, like my aunt, or ashamed or embarrassed to come back to receive healthcare because providers don't usually have the cultural humility or competence to show culturally diverse patients that they matter. So cultural competence, I feel like, could help medical providers reduce the amount of negative experiences, as well as ameliorate some of the consequences that come with having negative health encounters. So next we will talk about barriers to accessing healthcare for Black Americans. So some of these are that there's a really high cost, and there's a lot of stigma, um, and specifically stigma around receiving mental health services. And then there's cultural insensitivity on the part of the provider, which then creates distrust of providers, and due to mistreatment in medical settings, which then causes psychological distress for Black Americans. And so the lack of culturally validated treatments also increases the rates of treatment discontinuation here. So I just want to emphasize that Black Americans and many culturally diverse groups demonstrate resiliency through coping strategies that are retrieved from their culture. So, for example, when Hurricane Katrina hit, there were coping strategies that use spiritual and religious modalities that help the well-being of Black Americans, as well as just the social support. And these protective factors reduce depression or depressive symptoms and post-traumatic stress disorder, as well as socioeconomic distress. So it has been known that Black Americans experience like higher hospitalization and mortality rates due to COVID-19. And this has been seen historically with other public health crises or natural disasters. So extra attention needs to be given to Black American culture, which can create unique needs to overcome the health consequences of COVID-19 and any future crises that we may experience. So providers should be striving to deliver race-conscious interventions and building on strengths and resiliency factors of Black Americans that are trying to manage their psychological distress. This also needs to be collaborative in order to build trust. that might not be there right away due to the historical mistrust of providers. So next we'll talk about what mental health services are perceived to be the most effective by Native Americans. And some of these are the traditional services, so consulting family members, talking to an elder, offerings of tobacco, praying, working with traditional healers. So all of these were considered to be most effective in delivering mental health services. Only 33% and 24% of the sample size that was used in the study perceived talking to a counselor inside and outside the reservation to be effective, respectively. Also, the knowledge on Native culture is often incomplete. There are a lot of biases on the part of the provider, and yeah, their knowledge is just overall limited. And so there needs to be a holistic understanding of higher rates of substance use and suicide rates or mental health concerns among Native communities. And this is important for mental health counselors to know, and also for healthcare professionals to know, because it might mean that some Native clients or patients will benefit from spiritual identity exploration and honoring and integrating spirituality into the therapeutic process, which can help achieve better mental health outcomes, better health outcomes all around. So providers need to be aware of their own limitations as well around their expertise to avoid any religious cultural appropriation. Instead, it's better to know what resources are available, and instead of trying to attempt a ceremonial practice that wouldn't be appropriate. I think that knowing, resources such as like a Native healer to help facilitate the spiritual experience will be much more appropriate and appreciated. And again, this might not work for every client, but it's something to explore and to work on collaboratively with the client. And so factors that contribute to high rates of suicide and substance use in certain Native communities are the historical and transgenerational trauma, the systemic oppression and injustices, generational poverty, victimization, and untreated mental health concerns due to Native Americans not trusting service providers. So as you know, it is very common for counselors and providers to not have this knowledge. I was once in a capstone certificate program in the School of Medicine and Public Health here at UW. I was studying infant, early childhood, and family mental health, and we had these reflective supervision groups. And one of the colleagues that worked up north near a Native American reservation, she came in one day talking about how there was a Native American client, adolescent, who did not trust her, and she was dumbfounded that this person had strong interpersonal issues with her because she was white. And I guess this client had made it very obvious that they didn't trust this provider. And so then the provider, during our reflective supervision, was comparing herself to this client and saying how it wasn't her fault that she got an education, was more successful, so to speak, and that the Native American client could have done more to overcome barriers to receiving a higher education. So it was shocking to hear how insensitive this provider was to her client, and I interrupted her by sharing some of the historical facts and the financial factors that can contribute to Natives not attending high school or college due to oppression. So it's just important to do your own learning about colonialism and the different factors that influence health outcomes in culturally diverse communities. So I just want to emphasize here that diversity within the population and community does exist. So there is greater diversity within cultural identity groups. So not all Latinx communities are the same. There can be a mixture of Latinx from Mexican, Ecuadorian, Peruvian, Costa Rican backgrounds. And although a lot of values and traditions are shared among these Latinx groups, there are also a lot of differences in the way that people express themselves socially. So it is important, if you are ever doing research on a cultural group, that you keep in mind the population size and the representation of each group for the pool of participants that a study has. So not everything can be generalizable, and it's important to use your critical thinking to question and challenge assumptions. So research is very much influenced by the researcher. Something that is becoming more encouraged is writing positionality statements for research. And this gives the audience an idea of where the researcher stands in the context of the research topic. For example, if I were to study how family separation influences Latinx immigrants' resiliency, I'd share that although I identify as Latinx, I do not have negative experiences of being separated from my family due to immigration. And there is much more detail that can come into this positionality statement. And where to start would be to consider your cultural or social locations that influence your experience in this life. So then my main takeaways here are building cultural humility and competence is a lifelong process. There's no endpoint to learning. Culture is influenced by individual social locations, and both provider and patient client perspectives are shaped by culture. It's also critical to hear from the person or community being served what is most effective for care, again, through this collaboration. And then that culture influences interpersonal interactions. And I would just be careful when it comes to generalizing cultural groups, since there is much diversity among cultural identities. So then next, to complete our 15-minute lecture, I'd like to encourage you to watch this video, Cultural Competence in Health. I think I really enjoyed this video because I thought that the people or the clients or patients were speaking from each of their different perspectives. So there's a group of people from different backgrounds that are talking about what they need from a healthcare professional. So with that, I will leave you, and I hope that you have a great week. Thank you for listening.